Hey you, welcome to RJ Debate. Today we're chatting about euthanasia. Chill but punchy. It's a subject that really sits right at the intersection of medicine, ethics, and, well, deep personal faith. This isn't just a technical discussion about, MAID, medical aid in dying. It's really a profound conflict over who holds the ultimate moral authority when life is ending.
That's absolutely right. And we're asking, I think, the core question that defines our modern approach to life and death. Does the moral authority over the end of life rest primarily in the absolute nature of individual autonomy, the right to choose? Or does it rest in the intrinsic sanctity of life itself? My position is that life's sanctity provides an essential kind of non-negotiable floor, a rule that prohibits intentional active killing, regardless of how much suffering might be involved.
Right. And I'm going to argue, well, pretty much the exact opposite. I stand firmly on the side of individual autonomy. In our modern liberal society, arguably our highest moral value is the right of a competent adult to define their own good life, and crucially, their own dignified death. When suffering becomes unbearable, control over that final choice, it simply has to be prioritized. So let's maybe start with the foundations. If you look at influential modern ethical frameworks, whether you subscribe to Kantian deontological rights or maybe a more outcomes-focused utilitarianism, autonomy really is king. It kind of boils down to my life, my choice. And in this more secular view, dignity isn't some abstract inherent quality. Dignity means control. Control over your body, your experiences, your narrative, right up to the final chapter.
But doesn't that definition of dignity sort of collapse when control is lost? I mean, isn't that the problem?
Well, that's precisely the point. When we talk about suffering here, it's not just physical pain, although that can be part of it. It's often the existential agony of losing function, losing your personhood, the cognitive self that makes you, well, you. If you force someone to endure a state they explicitly define as undignified and meaningless, you are essentially treating them merely as a means to uphold some social principle, whether that principle is life is always sacred or doctors must never kill. And Kantian ethics, for example, tells us that violating rational autonomy like that is profoundly wrong. From a utilitarian angle, like Peter Singer might argue, the goal is to maximize the best outcome, which here is a peaceful, willed end for the person making the request.
Okay, I come at it from a fundamentally different worldview, one that is shared by billions across history and across many cultures. My position is that life is intrinsically valuable, full stop. It's often viewed as a gift, perhaps from a higher power, described with concepts like the imago Dei in Abrahamic traditions, or as a necessary stage in a spiritual cycle, like the concept of karma in Dharmic traditions. This value is inherent. It cannot simply be canceled out by personal preference alone.
So how do you define dignity then, if it isn't based on control or capability?
Well, in this framework, dignity is inherent and absolute. It cannot be lost regardless of physical or mental state. It doesn't depend on quality of life or productivity or capability. And when we approach suffering from this perspective, it's viewed as a profound mystery, yes, but often a purposeful one. For Christians, for instance, suffering can be seen as a path to salvation or maybe a deeper connection with the divine. For traditions like Hinduism or Buddhism, it is often viewed as a consequence of karma that needs to be consciously experienced and processed, not, chemically skipped over. So because of this intrinsic value, active euthanasia is seen as intrinsically wrong, or haram in Islamic terminology, because humans are viewed as stewards, maybe temporary caretakers, not the absolute owners of life.
Okay, that's a compelling philosophical distinction, especially framing suffering as a potential spiritual opportunity. But let's try and ground this in empirical reality for a moment. What does the actual data tell us about the motivations of those seeking medical aid in dying? Because if this were truly about, say, a failure to manage physical pain, we would need a revolution in palliative care. But the data strongly suggests the demand is driven by a different kind of suffering entirely.
You're referring to the motivation statistics collected in places like Oregon, I assume, where their Death with Dignity Act has been active for quite some time?
Exactly. The empirical evidence consistently shows the primary drivers are existential concerns, not primarily physiological pain. Year after year, the official reports show that really high percentages of patients cite things like loss of autonomy, I think it's around 86%, and loss of dignity, maybe 62%. Crucially, only about 31% cite concerns about inadequate pain control. This is huge, right? It means the patient isn't asking for MAID because palliative care is failing them physically. They're asking because they are facing an existential crisis, the profound loss of identity, meaning, and self-control. Palliative care is essential. It can manage pain, but it often cannot restore that lost autonomy or sense of personhood. MAID addresses that specific loss of control directly.
I see why you think that supports the autonomy argument, and I absolutely agree with your reading of the data. Existential suffering is the dominant factor. But let me offer a different interpretation of that very same data, especially looking at the numbers around social anxiety or perceived burdens. When nearly half, 46% of patients, cite being a burden to family as a key reason for seeking death. Well, that for me shows exactly why active killing is dangerous to society.
But hang on, isn't that still an autonomous choice? A deeply personal decision, perhaps, to alleviate a burden they feel they are imposing?
Well, it might start as autonomous, but the surrounding culture can transform it into a profound social pressure. Think about it. When the state legally validates the premise that, say, loss of physical function or dependence equates to loss of dignity, society can start to internalize the idea that the sick, the dependent, and the elderly are somehow low value, especially when healthcare costs are soaring. The supposed right to die can subtly morph into a perceived duty to die to avoid exhausting family finances or, emotional resources. And furthermore, the fact that providing access to excellent palliative care does not seem to eliminate the demand for euthanasia, as studies coming out of places like Belgium demonstrate well, that proves this isn't just about managing physical suffering. It seems to be about a social value judgment placed on dependence itself. I want to talk about the critical difference between action and inaction. We really need to distinguish active euthanasia, like a lethal injection, from merely withdrawing futile or overly burdensome treatment. The moral focus in, say, Catholic doctrine, the doctrine of double effect, or PDE, Islamic fiqh, the principle of niyya, and traditional Jewish law almost always centers on the agent's intent.
Okay, but if the outcome is the same, a peaceful, perhaps earlier death, why should we be so obsessed with what the doctor was thinking at the moment? Doesn't the outcome for the patient matter most?
Because intent, I would argue, is the foundational ethical line that prevents us from crossing into intentional killing. Think about the distinction carefully. All these diverse traditions generally agree it is acceptable, even commendable, to administer high doses of pain medication, like strong opioids, to relieve excruciating suffering, even if the physician foresees that the medication might indirectly hasten death. That's the doctrine of double effect in action. The primary intention is pain relief, not causing death. However, administering a lethal injection where the explicit and primary intent is to cause death is always seen as wrong. This ethical subtlety, it allows for aggressive compassion and comfort care without violating the fundamental prohibition on intentional homicide. The principle of niyya, intent, safeguards life, even while we're trying desperately to alleviate suffering.
I hear the sophistication in that distinction, I really do. But I'm just not convinced that the utilitarian consequence is irrelevant. From a practical standpoint, if the consequence is a peaceful end and reduced suffering for the patient, focusing so intensely on the doctor's internal intent, it feels a bit like semantic window dressing, perhaps used to justify inaction sometimes. And I would argue that the legal and practical reality already confirms how fuzzy this line truly is. Look, all major religious traditions, Catholic, Buddhist, Hindu, pretty much everyone agrees that stopping extraordinary or burdensome treatment, what's often called passive euthanasia, is morally acceptable. The practical result is often the same. Death accelerates, sometimes by stopping essential things like artificial nutrition or hydration. Now, you might justify it by calling it accepting the natural process, but in practice, you are deferring to the patient's autonomous refusal of treatment to effectively decide the time of death. This seems to reveal that regardless of the ethical framework used, whether I use the language of autonomy or you use the language of accepting the natural process, The practical focus ends up being on the patient's right to decide how they die and when.
Okay, and I agree we need strict safeguards, absolutely. But I think you might be painting with too broad a brush there, lumping all jurisdictions together as if they're identical. Well, look at the jurisdictions that adopted that subjective standard first, like the Netherlands and Belgium. Legalization has arguably predictably expanded far beyond just terminally ill adults. They now permit euthanasia for psychiatric suffering, a key example being the Shabbat case, which involved deep, intractable depression. And Belgium has even expanded it to minors of any age, provided they are deemed competent and suffering unbearably. This seems to confirm the fear. Once you accept that subjective suffering is the key criteria, there's arguably no clear logical stopping point that reliably prevents expansion into groups like the mentally ill, the disabled, or even children. The legal boundaries seem difficult to hold steady.
That is a powerful indictment of the subjective suffering-based standard used in the Benelux countries, and I absolutely concede that expansion beyond terminal illness is a major risk we have to take seriously. However, the risk of that specific slippery slope shouldn't automatically trump or deny the rights of competent adults who are suffering terribly right now under a potentially much more tightly controlled system. We do have jurisdictions like Oregon that demonstrate you can have tight, steep slopes, not necessarily slippery ones. Their law is strictly based on terminality, a prognosis of less than 6 months to live. They haven't expanded to psychiatric illness or minors in the decades it's been active. Furthermore, look at the counter paradox that was raised by the Canadian Supreme Court in the landmark Carter case. The court actually argued that the ban on MAID itself violates the right to life and liberty.
How does banning aid violate the right to life? That seems contradictory on the surface.
Well, it creates this awful paradox. If a person is suffering unbearably, but wants to maintain the control to choose their final moment, the absolute ban forces them to die earlier than they might otherwise choose. Why? Because they have to end their life while they are still physically able to self-administer the medication or perhaps commit suicide before the disease progresses and robs them of that capability. So by denying aid, you inadvertently force them to choose a premature, possibly violent, death out of fear of losing autonomy later on. You are, in effect, forcing death prematurely by refusing to support their desired timeline. The choice becomes dying early and maybe horribly, or suffering unbearably to the very end. That's not dignity.
So to sort of summarize my perspective, the core of this debate for me remains the individual's moral sovereignty. We have to respect a competent adult's own definition of dignity.
And as the data seems to show, when suffering is primarily existential, centered on that profound loss of self and control, to deny that choice feels like a profound violation of their moral sovereignty. The conceptual framework of martabat, or dignity, is deeply rooted in self-determination, in my view.
And the conflict, I believe, ultimately boils down to a fundamental clash over definition, over first principles. Is life something you possess and control, autonomy, or is it something you are given, something sacred, sacrality? We seem to agree on the practical solution of withdrawing futile, burdensome care, I might call it, accepting the natural process, you might call it patient autonomy. But we must reject the act of intentional killing, I believe, to protect the foundational value of all human life and, critically, to safeguard the vulnerable from internalizing a potential social obligation to die. For the many religious and cultural views, the concept of punditrion, or suffering, isn't necessarily something to be eliminated at all costs, but can sometimes be seen as a path to a greater good or understanding.
Yeah, this discussion really shows that the conceptual clash over what constitutes a good death and the very different meanings we assign to dignity and suffering is quite absolute, isn't it?
Absolutely. But it's fascinating that despite that really extreme philosophical gulf, the practical solution on the ground, like passively refusing aggressive treatment, is surprisingly convergent across almost all viewpoints. There's clearly so much more depth and nuance to explore in this material.
Wrapping up today's The Debate, I hope you got some new insights. See you soon. Keep curious.